And we have two very eminent faculties, as Raju has already mentioned. So I'll just give a brief introduction to both of them. From the global perspective, we have Dr. Christiane Weck. Is that how I pronounce your name, Doctor? Dr.
Yes, it
Christiane Weck. Right.
sounds good.
So, all right. So she's a senior palliative care physician working with the neurology department in the Agatha Reed Hospital in Germany. But as you can see, she has been associated with multiple other universities in various capacities. She is very active in the space of research as far as neuropalliative care and telemedicine is concerned since the year 2006. And there are various projects she is currently working on as well. Dr. Weck, I welcome you to this session. Next, we have for the Indian perspective, but very much a name in the global scenario as well, Dr. Roop Gursahani. He's a consultant neurologist and epileptologist in the Hinduja Hospital in Mumbai. He also is associated with various hospitals apart from Hinduja, and he is a visiting fellow in the Cleveland Clinic, USA as well. Sir is part of the steering committee in an interdisciplinary task force for intensivists, palliative care physicians, and neurologists for end-of-life care in India, a name which is very synonymous with palliative care in neurology. So I welcome you, Dr. Roop, sir, for today's session. So how would you like to go? Would you like to start with the global perspective first or the Indian perspective first? I would leave it to the faculty.
Yeah, I think let Dr. Weck start first.
Yes, yes. Even I was thinking the same, sir. So I think we'll do that. So Dr. Weck, over to you.
Yeah, thank you. That's great because I'm a bit excited, so it's good for me to start. Well, I will share my screen to you. I'm excited since I'm not so used to give English talks, so do not hesitate to interrupt me if you don't understand my English or if my explanations are not so good. So just interrupt and ask if there is anything that is not presented well enough. So I have, wait a minute, I have to share my screen. Sorry.
Yes, ma'am, your screen is visible. If you could put it on full screen mode as well, on the presentation mode.
In the presentation mode, yes, I have to, sorry, I have once again to try to put it in the presentation mode. Usually I'm not really sure. Yes, now it should work. Wait a minute.
Yes, ma'am. Okay, it was working.
Yeah, now it should work, isn't it?
Yes, it's working. Yes, yes.
Okay, so a very warm welcome to all of you, and thank you very much for the possibility to give this talk for the global or European perspective of palliative care and neurology. And I brought two projects with me this today that I'm working on, two projects that are set up to improve the care for patients with neurological diseases in a palliative phase. Wait a minute, sorry. So here are the two projects. One is called TANNE. It's a telemedical project for patients that are cared in an outpatient palliative setting. And we give a neurological expertise to these outpatient teams. And the second one is the PDPAL project, a project concerning palliative care for people with Parkinson's disease, a project of the European Union. Thank you for the introduction of myself. As you already mentioned, I'm a senior physician in in neurology and in palliative medicine. I'm working in both areas. I'm working in the south of Munich, a small hospital in Bavaria in Germany. And I'm also a research fellow at Salzburg, where I came in touch with the PDPAL project. Salzburg, a city in Austria where Mozart was born. And the TANE project, or the telemedical project, TANE is the acronym for Telemedical Answers to Neurological Inquiries in Real Time. So it's a German title. It's a project where we want to give our neurological expertise to outpatient palliative care teams that care for people with neurological diseases, or that have patients with other diseases but with neurological problems or symptoms. And TANE in Germany means this. As you can see, this coniferous tree. That's what TANE means. So we have conducted this project because we want to create a form of consults, neurological consults for palliative patients, and we want to transfer this to standard care. And this project is funded by health insurance companies in Germany, the Gemeinsame Bundesausschuss. And here you can see a map of Germany, and here you can see in red highlighted Bavaria. And in this area, we offer these consultations to the specialized palliative care teams, outpatient teams, and to the hospices. So in Germany, we have these structures, these outpatient care teams that care for patients with a high and complex symptom burden. And they help people to stay at home, even though they are in a palliative phase, even though they have those high and complex symptoms, and they help them to die at home. And hospices in Germany, I think, are the same structures everywhere. So hospices are the places where people can stay for the last month of their life until death, when they can no longer be cared at home. So these two structures are really important for our neurological patients, and we want to help those structures in caring for the patient, and we want to improve the care for the patients in these structures. We know that neurological neurodegenerative diseases benefit from palliative care, and even sometimes from an early integration of palliative care. So it's not only the motor neuron disease or amyotrophic lateral sclerosis that is already established in palliative care, but also Parkinson's disease or atypical Parkinsonian disorders are really benefit from a palliative care. And they, in the advanced phases, they often have high and complex symptom burden, so that the specialized outpatient teams are good structures that can care for them. And very often they suffer from speech disorders or dementia, so it's good to leave them in their familiar surroundings, the places where they feel safe. They have their caregivers that understand what they try to say with their speech disorders, and therefore these specialized outpatient teams are really good structures to care for them. The problem is that in Germany, usually there do not work neurologists in the structures. So the palliative care physicians that work in these teams are usually general practitioners or internal medicine specialists. And seldom there is a neurologist in these teams. And what we experience is that the symptoms those people have are very often different to the problems that oncological internal patients have. And so we think it's good to combine these two expertises, so the palliative care expertise and the neurological expertise. And the way we do is in a telemedical way. So we created this new form of supply. We wanted to give medical supply, enhance medical treatment. But we also want to enhance the job satisfaction of the teams because they are very often kind of afraid of taking care of these patients, since the clinical pictures are sometimes really different from the things they are used to care for. And we also want to enhance the quality of life for the unit of care. I will explain it a little bit later. So we think also giving this expertise to the relatives is somehow they will profit from. And we also want to make the structures more open for our neurological patients by offering this support to the teams. So that's the reason why we conducted this project or this trial and established this new form of supply. And as you can see here, our neurological ward is connected to the palliative care teams in a telemedical way. You can see the pockets the teams have with them. These are small pockets with a tablet and a Wi-Fi router in it. And the connection is established via the mobile phone net, and we have just a normal computer, and we have this telemedical software that is safe. So so it's a safe connection. And when we come to visit our patients at their home, it looks like this. So this is my boss, Professor Lorenzel. He's the one who, who initiated this project and is leader of this project. And you can see us while we visit different patients at their homes together with the teams. Here in the first lady is the lady, she's cared by the specialized outpatient team because of lung cancer. She is no longer able to leave her home because of the illness, and therefore she is not able to see a specialist in neurology, since in Germany, they usually don't make home visits. So the colleagues called us and said, maybe you can have a look at her. She looks as if she is stiff, is slowly, she makes so little steps. Can you have a look at her? Couldn't this be kind of a Parkinsonian disorder? And we had a look at her, and we also thought, yes, this could be. And we administered or we recommended to give her some dopaminergic medication, some levodopa, and she really benefited from this medication. Here you can see a patient with a motor neuron disease. He has a pseudo hypersalivation. And the colleague at the patient's home applicated or injected botulinum toxin in the parotid gland. He was instructed by my boss, Professor Lorenzel. Here you can see a patient suffering from Parkinson's disease, but also experiencing pain because of a polyneuropathia. And the colleagues also asked us to have a look at him, and we changed a little bit in the Parkinson medication, and we also gave recommendations on medication for the pain. Yes, so these are some examples of teleconsultations we made, and just to give you an impression what we are doing. We conducted a trial. The trial is now finished. It was finished by the end of May. So at the moment we are starting to evaluate the results. The trial was randomized, so we randomized the teams that participated in the trial, and part of the teams was switched to the intervention and a part to the control arm. And since we know that it will be a very heterogeneous population that we have to evaluate here, we have a multidimensional concept of evaluation. And we do a medical or evaluation of the medical effectiveness. So we measured symptom control before and after the video consultation. In the other dimension, we try to analyze the feasibility of the implementation into standard care. And this is the qualitative part of the study. So it's a mixed methods design. And then we have a health economic evaluation as well. So this is the design of our study. And as I've shown you, there are 46 teams and 17 hospices that we asked to participate. And there were at least 32 together that participated. We had problems with the recruitment. It was during the COVID pandemic, and I think most clinical trials have problems with recruitment at the moment, and so we failed our the patient number we should have, but we have 126 patients participating in the trial and 65 video consultations now to evaluate. I have two examples of patients that I brought to you because I want to illustrate two important aspects we mentioned during the project. And the first patient I brought is a patient suffering from motor neurons disease, from amyotrophic lateral sclerosis, and she is hardly able to communicate. And the team calls us and says, well, we have a problem, can you come to us? And the team usually also tells us which targets or which concerns we have to communicate about in our video consultations. And so for these patients, they ask us to have a second look at the situation, have a look at the medical setting, if the medication is right as it is. And they also told us that the patient is having aggressive breakthroughs. And when we came to this video consultation, this was the picture that we saw. And from the very beginning of the video consultation until the end, we had this patient which had this pathological crying all the time. And we explained to the relatives what is happening here, why she is crying, and we then made recommendations on medication. We said, well, it's a kind of depressive mood with aggressive outbursts, and for this and for the pathological crying, we recommend to give some selective serotonin reuptake inhibitors. And then for the pseudo hypersalivation that we also were able to assess during the video consultation, we recommended to give some amitriptyline. And what we experienced here in this patient was a common problem, or not a problem, but was a common phenomenon also in other video consultations. We experienced that it is good have a neurological expertise while caring for these neurological patients or neurological problems, since not all the neuropalliative care needs are correctly assessed by the team. So the team in this case wasn't aware of this phenomenon of pathological crying. So they didn't assess this need. And even if they assess the needs, they sometimes don't know about the potential for treatment of some of the needs. And that's also a part of the discussion. Before we started the project, we called all the teams, all the hospices, and explained what we are doing there. And one of the colleagues from a hospice asked me what we offer and where we help. And I explained that we also treat, for example, in ALS patients, this pathological crying, and he was really surprised that this can be treated. And that is not only not only has to be endured together. And that's one of the aspects we saw in our project, so that the neurological expertise is really sensible while treating neurological patients in a palliative setting. And the second experience we made is I brought you the patient here, the patient suffering from Parkinson's disease, and he's cared by the team, by the outpatient team, by the specialized palliative care outpatient team, not because of his Parkinson's disease, but because of his chronic heart failure. And here you can see his wife. She cares for him at home. And the problem is the patient experienced this weakness because of his cardiac decompensation, because of his chronic heart failure. And he got more and more stiff because they were no longer able to give him the levodopa capsules. He was no longer able to swallow them. And additionally, he had increased restlessness, well, we changed the medication. We changed the oral dopaminergic medication to roticotin patch, and we recommended to give water-soluble levodopa. We experienced that this really brings some effort if they only drink some sips of this soluble levodopa, and the patient was able to make some minor sips. We also recommended for the agitation that was reported, which could either be a levodopa withdrawal syndrome or kind of mixed delirium. We recommended to give some quetiapine, some neuroleptics. So this is, as I mentioned before, we made interviews, or a part of the evaluation is a qualitative part. So we make interviews and also with the relatives. And in this case, the relatives mentioned how enormous the relief was, that they no longer have to give this medication orally, and they are no longer the one that have to look that the patient really gets his dopaminergic medication, because they knew if he will not get it, he will get stiff. And so they really experienced an enormous relief by this change of application form. And they felt noticed, because we tried to explain a lot why we gave this medication, why the medication is important, which symptoms we observe, and how they can be cured, can be handled or managed. And they felt noticed, and they yes, they felt somehow educated, have taken something for themselves. And another aspect, it's not from this interview, but from another interview of the relatives, is that it's important for them to experience this period, this last period of life with a patient that is free of symptoms as good as possible. So these are the two aspects that I wanted to bring you from our TANNE project. Here you can see what we are usually asked for. We are asked for to control symptoms. Sometimes there are social needs where we can help to answer questions. Very often we are asked to give to have a second view on the patient, on the medication. Sometimes the relatives need respite care, and they ask us to take the patient for an inpatient visit. Seldomly we have the possibility to give a therapy for the underlying disease. There was a patient with multiple sclerosis where we recommended to give another boost of corticosteroids, for example. These are the diagnoses of the first 38 patients that we made teleconsultations with, and most of them are a neurological diagnosis. Not all of them are the diagnosis the patients are cared for in the outpatient teams. For example, the polyneuropathia are only diagnoses the patient have next to usually an oncological, internal oncological diagnosis. And some of the patients also had internal oncological diagnosis with cerebral metastasis. And here, this part of patients just had an internal oncological disease. And very often we are asked for patients that had a delirium. And a big part of these patients also had a delirium or sleep disorders. And then they also ask us in the video consultations. And yes, here you can see 5 patients suffered from motor neurons diseases, Parkinson's diseases, atypical Parkinsonian disorders. So it's a quite diverse picture of diagnosis that we were confronted with. Okay, so this was the part on the telemedical project. Are there any questions on this project or on this part? Otherwise, I will go on with the PDPAL project, a project for the care for Parkinson's disease, to pay people with Parkinson's disease in an advanced phase. And yeah, just interrupt me if there is any question. I also had the possibility to participate in this project. It's a project that tried to develop new standards for the care for patients with Parkinson's disease. And I want to tell you about the MOOC. MOOC means Massive Open Online Course. It's a course that was conducted or was set up to educate patients, relatives, and healthcare workers while caring for people with Parkinson's disease or patients with Parkinson's disease. And you will find it in the World Wide Web. Also, this project is a project with a consortium. I think I forgot to say that TANNE is a project with a big consortium behind it. And this consortium is funded, or this project is funded by the European Union. And the lead was in Italy, in Padua. And here, the Paracelsus University of Salzburg, Austria, also participated. Piret Pahl was the one who had the lead together with Stefan Lorenzel for the Austrian part. And one work package was this MOOC, and another work package was a systematic review. The systematic review is not published yet, but I hope it's going to be finished within the next weeks. And the systematic review is about early thinking palliative care for people with Parkinson's disease and searching for indicators for referral, timely referral, and current way of palliative care at the moment for these patients, and hindering and facilitating factors. And what was really impressive for me when we extracted the palliative care needs for these patients was that the biggest part of needs are informational needs, educational and informational needs. So they are named the most in literature, you can divide it into subcategories, and one is structural information, which structures exist that can be used by patients, which palliative care services exist. Some needs are on education about palliative care in general. So there is a misconception. People think palliative care is only for people with cancer, it's only for end-of-life care. So this is also really important need to educate patients, relatives, and also the neurologists. There's a need for disease-specific education, a huge need for also patients, caregivers, but also for professionals to adequately prepare the families for the end-of-life period, to be able for the healthcare workers to be able to give information about treatment, side effect, about the prognosis. So professionals need training about Parkinson's disease, about the palliative phase of this disease, and the unit of care needs training, guidance on how on end of life decisions, if they have to make an advanced care planning, they need information what means a feeding tube placement, for example. And so I only can recommend to you to have a look at this MOOC, at this massive open online course. It's a course that you can participate over 6 weeks. It's free to participate, so you don't need to pay for it. And it's on Future Learn, and so it really works on different aspects of Parkinson's disease, care principles of palliative care, management of Parkinson's disease. So it's really a good course on this disease. So yes, maybe you have a look at it. Here, just a little bit more detailed information about one of these sessions. Week 5 is now online, but you can have a look at the week 1 to 5 all the time now. Okay, so that's all I have to tell. I wanted to tell you. I hope I hit the topic I was supposed to work on. Thank you very much for your attention. Here you can see the TANE consortium, so the partners on the telemedical project. And it's Professor Lorenzle and Agatha Ried, the one who is leading the project, and it's Professor Piret Pahl in Salzburg, the one that is leading the project, the PD Pahl project at the Salzburg site. So thank you very much. And if you have any questions, please let me know.
So, thank you so much, Dr. Weck. Yes, sir.
So can I? Yeah. So Dr. Weck, that was very good, because that really sets the stage for my talk. My talk is diving into how the entirety of neuropalliative care is can be handled. So what I'm going to do, I think, is I'll quickly run through my talk, and then I suppose we should be able to take questions. And I strongly recommend that if any of you have questions on whatever we have spoken about so far, you should be able to put them up in the chat box, and we'll take it from there. Those of you, I'm not sure if people who are attending this course would have been there at the Indian Association of Palliative Care annual conference at Bangalore. Deepak, you were there, I guess.
Yes, sir. I was there, sir.
So yeah, so you will have heard Dr. Stefan at the meeting. He was there. He was one of the lead speakers in the neuro track. I will actually connect from my laptop and I'll start my presentation. So in case anybody has a question or two for Dr. Weck, we can finish that off until I connect, because I'll log off from this and log in from my laptop. My laptop doesn't have a video camera, so I will vanish now.
Sure, sir.
Yeah.
In the meanwhile, I would request others to please feel free to start posting your questions on the chat box, and so that we can start looking at them, and maybe collate a few questions together and ask it to Dr. Weck at the end of the session.
Right. I'm audible?
Yes, sir, you are.
Yes, sir.
I'll just start screen sharing. Right. Can you see my screen?
Yes, sir. Good to go.
Right. It's great to join a Pallium India audience again and to meet old friends. Dr. Weck, I'll say this again. It was a pleasure to listen to your talk, because Stefan, of course, did tell us how this project was going, but you've actually given us the nuts and bolts of it. So it's quite a revelation for me personally. What I'm going to do is try and bring it to people from India on as to how they could probably apply these in their own practice. So my learning objectives are to understanding the scope and relevance of neuropalliative care for our practitioners, appreciating the differences and similarities in providing palliative care in neurological illness and cancer, and finally framing the domains of care. I'm not sure if any of you saw this interview by Irfan Khan, who died of pancreatic carcinoma. And but there are some quotes here that actually tell you how different oncopalliative care is from neuropalliative care. One, of course, is this: the physical pain. And the second is, Irfan, at the end of his life, he knows he's going to die. And it's a quote that still brings tears to my eyes. I mean, what a brave man. So if we look at trajectories to death and disability, these are the trajectories that are there for practically everything. This is the short period of decline that is typical in malignancy. This is the entry and re-entry looping trajectory that is typical of organ failure. Then this is the trajectory of prolonged frailty and decline that occurs in dementia or in old age. And this is the trajectory that you see in critical illness. And in critical illness, you know that somebody is hit by something that would normally have caused them to die, except that critical care rescues them and they carry on for a certain period of time. So how does this apply in neurology? Like systemic malignancy, amyotrophic lateral sclerosis or motor neuron disease can behave the same way. Of course, glioblastoma multiforme and metastatic disease, malignant disease are obviously going to be similar. But there is also a rare condition called Creutzfeldt-Jakob disease, which causes rapidly progressive dementia. Then if you look at this entry-re-entry trajectory, then you do see this, which of course is typical of organ failure, but you do see this in some cases with bad epilepsies. They get admitted with status, come out not so good, or with multiple sclerosis. Alzheimer's and Parkinson's are the prolonged dwindling trajectory, and the critical illness trajectory in neurology has hypoxic ischemic encephalopathy due to cardiac arrest and return of spontaneous circulation, but leaving behind brain damage. Traumatic brain injury is such a tragic entity in younger individuals, and then you have massive strokes of various kinds. So if you look at the various conditions that we have to deal with, I'm sorry, I'll just have to mute and answer a call. I think it's from the hospital. Can you mute me, please, for a minute? Yeah, I'll actually turn my phone off. That's the only way to. Okay, so the conditions that require palliative care is this whole list: dementia, Parkinson's, MND, stroke. But you also see patients who are at the other end of life. Children, congenital brain malformations, perinatal brain injury, progressive neuromuscular disease, and so on. All of these also require palliative care. We've already touched on people who develop severe acute brain injury, and I'll just skip this slide. But the common medical themes that you see in all these patients are essentially in three broad categories. The first is cognitive loss, which means thinking capacity goes down, together with the appearance of dementia and delirium, which Dr. Weck told you about, and patients also develop behavioral and psychiatric symptoms. Then motor impairment. Typically, non-neurologists recognize pyramidal, which means weakness. But there are patients who have extrapyramidal or Parkinsonian features or lower motor neuron findings. And of course, seizures and epilepsy are a pretty common factor too. Now, if you look at it, do palliative care physicians really need to learn neurology? I wouldn't think they need to learn all of neurology, but you have to remember that the bulk of non-onco palliative care is neurologic. Then why is general standard palliative care focused on oncology? Partly it is legacy. Remember that cancer patients have voice. If you are running a not-for-profit, then it makes oncology is easy to handle in the sense that the patient, the budget, the commitment are all limited and all expire together. But when you look at the broader community, remember that government, community, volunteer-based organizations recognize needs and suffering, and they don't really bother about medical specialties. But the problem is that the neurological patient is voiceless and the commitment can be indefinite. So you've seen this from Dr. Weck's experience, that the bulk of the care has to be handled by the family and at home. Do we have numbers? Well, from Kerala itself, this is probably the only statistic that we have in the world that when Mallapuram began, which was the first of the neighborhood networks, almost 90% of their work was cancer. As palliative care has taken root and spread in Kerala, today Mallapuram's work is only about 30% cancer. And if you look at this, we have not really looked at these diagnoses and symptoms in detail, but I have a feeling that the bulk of this is neurologic. So please understand that for anybody who's coming into palliative care now, in the future, you will be looking after a lot of neurology. Again, there was a little bit of a hint of this in Dr. Weck's talk. Why don't neurologists take part in palliative care? Well, one is they feel they're basically unaware of available services and they believe they know everything. From palliative care, the biggest barrier is that they feel that they cannot handle neurology. And in fact, I'll come to that at the end. There is a solution to that. If you look at oncology, we work with a kind of a bow tie model where at some point oncology hands over to palliative care. And that does not happen in neurology. In neurology, a neurologist is responsible for a patient from diagnosis through life events, symptoms, the increase of disability. Some patients, of course, with disease-modifying therapy will survive, but other patients have to be taken through serious illness conversations, advanced care planning, until eventually, there is a kind of a choice between natural death and life-sustaining therapies at the end of life. Throughout this, it's crucial for us to support the care partner. Medical aid in dying, although I've included it in this map, is not really an option for us in India. If anybody is interested in this, this review article is free in the National Medical Journal of India, and you can download it. Basically, I've kind of reviewed neuropalliative care for India. So I'm going to just talk about two patients and then a third to explain to you how this works. The first is this patient with dementia, who started off in 2014. When he was diagnosed, he needed treatment for mild depression, and he himself asked the neurologist what is going to happen, but he got no answers. He had been declining for about 2 years before this, and he'd given up his responsibilities. And as often happens, he and his wife were living in Mumbai while his two children were settled in the United States. And you can see the way his decline went on year after year. In 2015, the only thing that happened was he got once lost in the neighborhood, but his wife was bothered by the fact he would keep on asking questions again and again. In 2016, he started to need more and more supervision, especially at toileting and bathing. And by 2017, behavioral changes had appeared. He needed to be pushed for a bath and he would get angry. There was one episode of nighttime wandering, and the main care partner needed admission for ischemic heart disease because she was getting exhausted. Early the next year, he came in with encephalopathy due to urinary tract infection. A hypofunctioning detrusor was found, and he was discharged with a suprapubic cystostomy. And when he came out, he was still mobile, but his speech had gone down substantially. And now the wife asked the neurologist, what's going to happen next? Again, no answers. End of this year, continued to decline. And then when he got admitted again with hyponatremia, when he was discharged, he was completely dependent. But watch what came next barely a month later. In a month later, he got admitted with recurrent seizures, was intubated, was treated with anti-epileptic medications, and he could easily come off the ventilator. But for reasons that I wasn't still sure about, he got a tracheostomy. I wasn't involved. I came in only around out here after day 8, 9, 10, somewhere around that. And then came the question of putting in a peg. And at this stage, the family was absolutely, they needed a lot of discussion. And finally, he did get discharged. On discharge, he was in the persistent vegetative state. And the family actually asked the hospital, couldn't we have involved palliative care earlier? Well, he was managed at home by his 82-year-old wife. Our palliative care section was available for telephone consults. As you can see, that actually works quite well. And about 1.5 months later, he aspirated and passed away. So if you remember the beginning of this story, when there is early memory loss and there may be a little bit of depression, what are our priorities? Our priorities are to sort out pending business. You may treat depression, you may consider medications for cognitive symptoms, but you start supporting the caregiver and you sort out pending life business. How do you do this? Well, the first is you tell the patient the diagnosis, and you can do this using the spikes protocol. The spikes protocol, you actually don't have to give too much information, but you can tell them what comes next. And you tell them that in the diagnostic phase, you tell them that in the supportive phase, and so on. But if you remember the map that I showed you, when a patient enters that map, as physicians, we are the Sherpa. We know where this road ends. It's our business to help them through it. Of course, you don't have to go into the full details of prognosis, but if people do ask, we answer this in terms of these two questions: how long and how well. Unfortunately, in dementia, this how long question is very, very difficult to answer in the beginning. If we are looking at the basic components of prognosis, and this applies everywhere, people want to know about death, they want to know about disease progression, they want to know about disability or other decline. In oncology, drug toxicity is important, and so also are the cost of treatment. But what you can do without going to the details of this is to prepare them for upcoming signposts of decline. So, for instance, here, the things that were coming up in the next couple of years would have been told. Of course, you have to manage uncertainty, and ideally we frame the trajectory in the best worst case framework. So when somebody begins living with dementia, remember that the first priority is unfinished business: legal, advanced care planning, and family. Of course, behavioral and psychiatric symptoms can come up pretty early. There's a risk of abuse, and you have to prepare to care for the carers. Just to tell you about a little bit about advanced care planning, most of you will have heard about the Living Will and the Advanced Medical Directive, which is now both valid and legal and in India. But it is part of a much broader process in which adults at any age or stage of health understand and share their personal values, life goals, and preferences so that they receive care that is consistent with those values, goals, and preferences when they become seriously or chronically ill. Now, how does this work in dementia? Well, we'll come to that a little later. I'm sorry, has this slipped out of my... I'm sorry, I think those two slides are missing. So there has been a recent change and an evolution in the way ACP is defined for dementia, in the sense that it now includes continuing the conversation with the family as time goes on. Now, essential components of the Advanced Medical Directive are, first of all, assigning a healthcare power of attorney. So ideally, say for instance, if this is an individual who has multiple children, then you have to ask them, who do you want to make decisions when things go wrong? And then you may have to talk to them, what happens if you go into the ICU? What happens if you need this? Would you want to tell us more? And then, of course, as time goes on, these medical orders for life-sustaining treatments can be discussed with the family. Now, if you look at this, had this conversation been had with our gentleman right at the beginning, maybe things would have been substantially different. As dementia worsens, they start to have problems with behavior. They get more and more dependent, and then you have to assess them for safety. You have to start giving more and more support to the caregiver, and then finally look at care needs and where their care will be managed. In India, we don't have much of a choice. It's always home. but elsewhere you might need to look at this. Now, behavioral and psychiatric symptoms are seen in a wide range of neurologic illnesses, and you can get delusions, hallucinations, anxiety, depression, irritability, wandering or pacing, disruptive vocalization. So there are conditions like progressive supranuclear palsy where the patient will be going non-stop, 24 hours. And that leads to sleep disturbance for everybody. So when you screen for these symptoms, for the patient, you can use a single item question. How do you feel? Are you feeling anxious? Are you feeling sad? And even patients in moderate dementia could probably answer this but of course, they will be able to tell you how they are at that moment. For both the patient and the caregiver, are there any behaviors that worry you? And when you have to manage, you have to assess the level of concern ranging from annoying to dangerous. So the way we handle it is we use the ABC framework, see what sets off that behavior. What is the behavior? Is it just a little bit of shouting, or is it actually physical? Does the caregiver get a slap? And what are the consequences? I mean, a younger caregiver might be able to handle that slap, but an old lady would fall down and break a hip. So you have to decide how significantly you want to treat them. What palliative care often doesn't, in onco-palliative care, look at is mobility, falls and injuries, but these become a prominent part of managing neurological issues. So for instance, in Parkinsonian disorders, what we do is called the get up and go or the pull test. So get up and go is whether somebody can get up from the chair, take 3 steps, come back and sit down without losing balance. Or you stand behind them. Of course, you have to be supported against a wall and you give them a sharp tug and see if they can hold their balance. Occasionally, patients may have seizures and they can fall with that. So what can you do? You need to improve balance, and physiotherapy is very, very important, but you need to assess risk also. If it is not possible to prevent the falls, then you mitigate them by assessing bone mineral density, giving vitamin D and calcium supplements, or even bisphosphonates. The next issue that comes up is the carer. Now, I try and identify 3 roles. The first is that of a care partner, and typically this is in the early stages of the illness, especially say for instance of Parkinson's, when the patient is able to come and the care partner is important only for logistics to make sure that they come there. And then the level of dependence increases, and then that becomes a caregiver. In India, we are still able to hire paid caretakers or care assistants. At least most people in middle-class families would be able to manage that. I mean, because there is no way you can manage them at home without this. And you need to focus on who cares and why. What is the relationship? This is especially true when it's a family caregiver. What is the age and health status of the caregiver? Do they have other commitments? Not only is the caregiver role important for physical assistance and guidance and support, but as time goes on, they will also be the main surrogates for decision making for these same patients. And the impact on the caregiver is substantial. Health impact, psychiatric morbidity, the risk of burnout, more importantly, anticipatory grief. As you take care of somebody who is fading away with dementia, the sense of loss is significant. You can assess this with something called the Zaret burden interview, but probably the best way for us to do anything about it is to acknowledge that in Hindi, the term that we use, acknowledge their seva. Support groups are important, and you may need to look at bereavement counseling. Once dementia gets advanced, not only is the ability to have a conversation gone, but choking and dysphagia is known, and towards the end, pneumonia, weight loss lead to multiple hospitalizations. And then you have to reassess goals of care and therapeutic interventions. Ideally, deprescribing also comes in at this stage. And you have to prepare for the end of life by warning the family about possible complications and deciding whether or not to admit. Even a decision like IV antibiotics for a urinary tract infection at the end of life is a decision. You might focus on just symptom control and let the old lady, old gentleman pass on in peace. Feeding difficulties are going to happen, and feeding tube placement, sorry, the word tube is missing here, and its removal are important considerations. Ideally, when it is dementia, we prefer, and the family has to be explained that this patient needs to be fed by hand. Unfortunately, very often what I find is that the patient gets admitted to a unit that has no experience of this, and a ICU is put in, and then that is something that has to be managed at home. So let me move on to the next case. And this was a practicing lawyer. He first came in to see me for difficulty in using the right hand. There was clinically obvious wasting and weakness, and I made a diagnosis of motor neuron disease. That was confirmed on EMG. But the reports were not brought in by him. His wife and his wife's younger brother came in, and the first sentence they told me was, "We do not want him to be told." Collusion. So at this stage, what I usually do is suggest a second opinion, but I had done one thing more. At the time of the original consultation, I had told the patient that if he wanted to speak to me directly, I would be transparent with him. And that is what happened. Once they went back home, the patient obviously insisted on joining us, and they were also by then convinced that it was important to do that. The second opinion had confirmed the MND, and I could tell him the diagnosis using the spikes protocol, and he was started on the medications that are available. Not that they're very successful, but you started on medication. And here you can see the timeline of decline. November 2017 is the diagnosis. February 2018, he started physio. And in this visit, they came and asked me whether they could go for stem cell treatment. I told them that that was a scam. And he accepted that, and the wife and daughter joined the support group that is run for MND in Mumbai. With physio, although he had speech difficulties, his mobility was completely intact, but he did start to lose weight. And then the main encounter occurred in September 2018 when he came in, and because the speech was getting affected, I had to talk to him about a peg. At this time, he actually came in a wheelchair, but he could still converse comfortably. And I actually broached a spiritual question. Are you at peace? So this is a single item question that brings out spiritual issues. And if somebody wants to explore this always opens up a conversation. And he, in fact, talked about things that he wanted to clear up. And as part of the conversation, I talked about PEG. I had explained to him that PEG would give him extra months of comfortable life. So he got a PEG. You have to do a pulmonary function test before percutaneous endoscopic gastrostomy is done. And when I made a home visit, almost about 4 months later, although he was losing weight and although his speech was limited, he was still taking some amount of food orally. His only grouse was that my foods all need to be mashed. He was being taken care of at home by a paid caretaker through the day, since his wife was a working professional and she would manage at night. Another 3 months later, he started to require round-the-clock morphine. NIV had already been started by then. His married daughter was now spending alternate nights at home so that her mother would get a night's sleep. And then in October 2019, his wife was alone at home for some reason one evening. And when he finally passed away, in fact, I think we missed the decline towards the end. He was rushed to our emergency and was declared dead. So remember that when you convey the diagnosis, the warning shot is important. You have to proactively address collusion and denial. there is always some amount of diagnostic uncertainty in the beginning, and that needs to be tackled. All therapeutic options have to be discussed. And if you do this right, then you are actually building trust, because you have to prepare for the long haul. And very often you call them in again at 2 to 4 weeks for more substantive discussions, because in the initial period, it's obviously something that is, well, obviously life altering. Remember that the symptom burden as this goes on in life-limiting neurological illness is as much or more than in terminal malignancy overall. But the symptom profile differs. Although physical pain is present, it's actually mainly neuropathic and is probably less. But there's a lot of psychological, social, and spiritual pain. And this has to be assessed before communication is lost. Afterwards, it seems to be reflected in how the caregiver responds. There are multiple symptoms specific to neurologic disease, and we've touched on them a little earlier. You will get this presentation, so you don't need to worry if you don't get everything on each slide. But the point that I want to tell you is that in patients who have a lot of motor issues, rehabilitation has to be built into the management plan. Ideally, if there's a disorder-specific multidisciplinary team, that will be good. But otherwise, you can work with your regular physiotherapists. Aerobic exercise is best. If supervision is possible, then in the early stages, you could try a little bit of weight training. But range of motion exercises at home are always possible and should be done. Occupational therapy, speech and swallowing therapy, cognitive rehab are also all important. Remember that palliative, rehabilitative, and curative care are actually overlapping domains of care, and we have to work together. As the patient deteriorates, communication will become more and more difficult, and you have to anticipate and plan early, including involving the speech therapist. If there are speech problems, meaning in uttering words, then one simple thing to do is ask the family to write down the patient's questions in advance of the clinic. You establish clear yes/no signals, but don't pretend or assume you have understood. There are more and more techniques that are available called augmentative and alternative communication, which depend on technological capacity. For instance, if you remember, there was a simple model that was used in this patient, a laser pointer that was attached to a zero power specs, with which he focused on a letter on a large whiteboard in front of him, and he could pick out letters and form words. In somebody who has cognitive impairment, here we are talking of speech output. Here, the content of speech itself is gone. Remember that even in somebody who has dementia, respect is important. And you have to use simple words. Remember that how you make them feel is what they will remember literally till the end. To understand distress or pain, you may need special skills. There are certain symptoms that are pretty common in motor neuron disease, spasticity, cramps, and fasciculations, and pharmacological treatment is available for them. I'm going to skip this. Other problems such as autonomic, which is pretty prominent in the Parkinsonian syndromes, drooling, which is again seen in Parkinsonian syndromes. And if you remember, Dr. Weck's patient received a tricyclic antidepressant to control the drooling, and the pseudobulbar effect, which she showed you a patient with. Again, we do use antidepressants there. When do you start having serious illness conversations? When the patient gets hospitalized, when there's a surprise question if the patient will survive the next year or not, or if there's a major decline in functional capacity, or decreasing nutrition, and so on. But there are also indicators within the individual conditions that you will be looking after. Now, one key thing to remember is that as these patients near their end, nutrition, hydration, and ventilation are two major issues. Now, if you look at somebody who has motor neuron disease, this is called a lower motor neuron disorder. There they will start having swallowing failure, then breathing failure, and if these two are sustained, then they will end up in what is called the locked-in state, where they have no movements but may still be awake. In dementia, cognitive failure leads to bulbar failure, difficulty in swallowing. Typically, respiration persists right till the end, but they can go down further and further and end up in the vegetative state. In patients who are in between motor versus cognitive, these are the Parkinsonian syndromes, and here this will depend on the individual trajectory. Some patients will have more motor, some patients will have more cognitive. Remember that quality of life depends on personhood. So if it is more cognitive, then the quality of life goes down further. So you have the choice of putting in feeding tubes, either the Rice tube or the percutaneous endoscopic gastrostomy. PEG has a reduced risk of aspiration and a better body image. And we recommend PEG in motor neuron disease because since you kind of give rest to the upper pharynx and larynx, you delay the onset of respiratory failure and you can prolong their lives by 6 to 9 months. On the other hand, in somebody who's going down with dementia, clinically assisted nutrition and hydration is not recommended. And you can understand that you are going to help a patient survive in the vegetative state. What about ventilation, especially in the motor neuron diseases? Respiratory failure is predictable. When they have nocturnal hypoxia, they wake up in the morning with headaches. They'll be sleepy through the day, and you can monitor saturation. Non-invasive ventilation with BiPAP and dyspnea control with morphine works for a fair number of patients, but some patients may choose, or their families may choose, to have invasive ventilation with tracheostomy. And these patients eventually end up in what we call the locked-in state. Unfortunately, when this happens, the quality of life for the patient stabilizes, but the carer's quality of life keeps going downhill. I'll skip the slide to speak about status epilepticus and palliative care. Remember that multiple medications are available which can be given subcutaneously, and you have to decide how aggressively these patients will be treated. Remember that visible seizures are distressing for caregivers, but ongoing status eventually becomes subtle or subclinical, and then eventually respiratory arrest occurs. You may have multiple difficult decisions at the end of life, like eating and swallowing difficulties. We've spoken about them, agitation, restlessness, and planning on ending treatments. Again, I'm going to skip this slide and come to the last section, which I'll be going a little quickly through. And this is the story of neurocritical illness. I told you that there are patients who will be hit by a truck, a bullet, a clot, a bomb, and they would have died except for the fact that modern critical care pulls them out. But modern critical care in somebody who is in coma, the chances that they will reach normalcy is actually not really high. If anybody has been in a GCS of under 8 for longer than 6 hours, the likelihood that they will come back to normalcy is relatively low. Some patients will still go on to die, some will end up in the persistent vegetative state, and some will improve, but with significant disability. So this is the story of a 45-year-old man, my patient, who came in with hemiparesis, gradual loss of consciousness, and it turned out that his basilar artery was occluded and his brainstem was infarcted. We tried a thrombectomy, which failed, and he ended up on the ventilator. But over the next few days, there was a gradual impairment in consciousness. Now, when you get somebody in catastrophic or serious acute brain injury, in the initial period, up to about 3 days, you have multiple rescue possibilities. It could be surgery, it could be thrombectomy, as in this patient, but these are rescue or salvage therapies. The other point that comes up fairly early is in somebody who has such severe brain damage that they are brain dead. And then it becomes important to determine brain death. But if patients have gotten through this, then the intermediate one is the one decision point is the trickiest, and unfortunately the one that is often where the decision is not made right. This is a fork in the road where the family has to consider between tracheostomy and PEG versus extubation and palliation. And it's our business to help them make this decision, because if they end up in the persistent vegetative state or the minimally conscious state, then very often at the end of a year or so or more, the family will ask about withdrawal of artificial nutrition and hydration. I'm going to skip this to end this and bring you to the point that when you start discussing with the family about this, you have to explain substituted judgment. The family may say, I want him back home. You have to explain to them that this is not about what you want. You are the person who knew her best. As her representative, you have to tell us what she would have wanted. And how do you think she'll be 6 months from now? So this is where this discussion changes. Who are appropriate surrogates? In India, unfortunately, there is no legislation that sets this out. But recently in 2020, All India Institute of Medical Sciences put out an end-of-life care policy, and they have listed the hierarchy of surrogates. So it's the spouse, available adult children, then parents, then siblings, and then anybody else. And in case of doubt, remember that you have to follow this hierarchy, and you have to do due diligence to make sure that the people who you're making these decisions with are appropriate surrogates. I've already told you that outcomes in medical coma are not very good. So a GCS of equal to or less than E2, M4, V2. Well, the duration is and lasting longer than 6 hours. The likelihood that they will come back without disability is low. So can you decide at this point who is going to do well and who is going to do badly? There are clinical indicators that help us make these decisions, but it is up to us to communicate that to the family. Somebody needs to be muted, please. So in this patient, what I told them is that the best case is that he may speak, may eat by mouth, may walk, but he is going to be dependent for all activities of daily living. It's unlikely that he'll go back to work. The worst case is that he may never leave the hospital. But my guess is that he'll reach a point where he'll be bedridden, but will recognize and respond to the family. Now, there was family dissension, mainly because of funds, but the wife was unwilling to withdraw. And in that process, tracheostomy and PEG was placed only after 19 days. Eventually, he got transferred to a small nursing home close to his residence, but he passed away 3 months later. When you give this prognostic estimate, remember that you have to consider whether there had been any verbally expressed wishes from the patient. You also have to look at the age and the prior functional status, because nobody is going to return to a state which is better than which they came in. We also have to look at the caregivers. Do they have motivation? Do they have resources? When you do all of this, you're able to enter into what is termed shared decision making, where our input about prognostic estimates goes together with the patient's goals and values, and you can set goals of care through shared decision making. And as I have said earlier, this conversation needs to begin when the prognosis becomes clear. You can get some idea of prognosis by day 3, but definitive prognosis is possible by day 10 to 20. The issue is very often in ICUs, patients end up getting a tracheostomy and a gastrostomy earlier than that, and the patient is then moved out. But families need at least 10 days to 2 weeks, in my experience, to come to the point of making this decision about whether to withdraw or to go on. Now, in India today, we have the legal basis for these withholding and withdrawing decisions, and these are various documents that I and my group have worked on, all based on the 2018 judgment, which clearly says that all adults with the capacity to consent have the right of self-determination and autonomy. If a patient has made a valid advance directive specifying that he or she does not wish to be treated, then such a directive has to be given effect. This is the law of the land. How do you proceed with it? You may have heard about a stepwise process. And again, I won't be going into the details of that, but remember that all large hospitals should be able to carry this out. Now, when you do this, withholding and withdrawal are medically, ethically, and legally equivalent, but to the layperson, withholding is emotionally easier. So what we tell them is that extubating, because obviously the endotracheal tube cannot stay on beyond 2 to max 3 weeks, we tell them that the extubation is a medical decision, but whether or not to put the tracheostomy is their decision. And families find it easier if we frame it as withholding tracheostomy. When this happens, we perform the extubation in the ICU after having assured the family that the patient will not suffer any symptoms. You symptomatically manage the patient through this period. If the patient begins to breathe and is otherwise comfortable, you can move them out under the care of the palliative care team. I'm going to skip all of this because there's something more that I need to speak about, and that is this. Remember, if you have heard this, there are 3 big things in neuropalliative care. One is communication. Dr. Weck spoke about that information is lacking, and that's something that families miss. There is the aspect of loss of personhood. The person who began the journey into dementia is no longer there towards the end. And there is huge uncertainty, especially about timelines. But there's also uncertainty about access to information and support. So how do you manage patients through this? And if anybody is interested, you can read what I put up here. But you have to address this under domains of care. And there are 8 domains that are important. Sorry, I think this got missed. They include structure and process of care. Where is the patient going to be taken care of? Who is going to do this? You have to address this. Then you have to assess physical symptoms, psychological care, and social and spiritual issues. And then finally, you come to cultural aspects, terminal care, and ethical and legal aspects. If anybody is interested, this is a document that is available free for download. It's a American site, and it's extremely useful. If any one of you is interested in learning more about neuropalliative care, then I am part of the International Neuropalliative Care Society. In fact, Dr. Weck spoke about Piretpal. She is one of the consultants for the INPCS certificate course that we run out of India with inputs from all over the world. And you're welcome to look this up on inpcs.org and perhaps join. I'm going to stop at this point. You'll be getting this presentation from Palliative, but let's take questions.
Thank you, Dr. Weck and Dr. Roop. We have a lot of questions already in the chat box.
Yep.
Yeah, I think we'll take it up one by one. I think the first question is, what are the information that we can give to the attenders with Parkinson's disease? And before moving on to the responses, I'm really thankful to both of you, because what we have discussed today is something which is really doable, and this is exactly what people like us want. Many of these participants work in isolation and in very difficult areas where they may not have an access to a neurologist. And Dr. Weck talked about a very effective way how they have conducted through telemedicine. Like, this is really, really helpful, something which can be adopted. And Dr. Roop, you also have discussed the real life situations, not a theoretical situation. So that's a real encouragement for all of us.
So if
just
there are any
taking
live
questions.
questions, what I'll do is I'll look at the
Yes.
chat box and see if there are answers that I can give directly. So any
Sure.
questions that people want to open up and speak, we can kind of answer.
Yes, Dr. Prakash, please.
Hi, good evening, sir. I'm Dr. Prakhar. I'm a critical care consultant here at Calcutta. And the cases which you have presented is what we face every day over here at work. So I have 2 specific questions for you. Number one, is about the palliative extubation which we do. So
Yeah.
I looked because I have been facing this issue very frequently in my ICU. I looked up in the literature. There is not much literature supporting that palliative extubation, and the colleagues, neurosurgical surgeons and neurologists are very afraid of the legal framework, about working with that. And second issue, if I can ask this, suppose the patient is already having a tracheostomy. We have done a tracheostomy, and after the tracheostomy is done, after a few days, they are now thinking about withdrawing that tracheostomy, withholding it because they did not know the implications earlier on. So what about palliative decannulation? Is there any harm in doing that? Because this patient might be bedridden, and sometimes they do wish कि tracheostomy remove कर दो, मेरे घर पे कोई है नहीं care करने के लिए.
So, okay. So the first question first, I think the legal framework for all of this is established through the 2018 judgment and the subsequent amendment that came through in January 2023. And I strongly recommend that all of us who are in the field have to educate our colleagues about what is possible legally. It's something, it's a barrier that we all have to work at. And as I said earlier, I of course flipped through that slide, but the process for doing that is now getting set. And just, I suggest you keep in touch with IAPC. We'll be putting out this information through IAPC. The second question about, well, if you are decannulating a patient and you proceed with the standard format of palliative care. If the patient is under palliative care, when you decannulate, your priority is to make sure that the patient is comfortable. Of course, if this is done in hospital, then you have to follow the legal procedures that were done earlier. If it is at home, then it might be simpler. But again, we do recommend that these decisions not be taken by one doctor and one family member. They need to be broad-based before you get to making these decisions. So I'm not sure if I've answered it completely, because it all depends on individual cases. But if you watch out, there will be information on IAPC.
So what about the outcome after decannulation for these patients? Is there any literature showing that the outcome is good or worse or same as if they're
No, I
having
mean, it really depends on whether the patient is able to manage their airway or not. So that is not something that you can predict. I mean, you're basically focusing on making the patient comfortable and making sure that the family is able to handle it. Right. Next, anyone else? Dr. Sridevi, anything for titubation?
Yeah, there are few questions in the chat.
I know. So I think these are all very specific questions.
Yes, these are all
go through them.
purely medical. Yeah.
Yeah. So, Dr. Weck, would you like to take
The questions in the chat?
Yeah. Would you like to answer? Take any one of them, and then I'll go back to the.
Well, I can try to. Well, let's start at the top. With which information to give to the carer of the Parkinson's patients. So it's a quite a broad question. I fear I can't answer this in a short.
These are actually really very specific, and obviously it shows that you people are actually managing patients and you're running into these problems. I strongly suggest that you either, if you have more of palliative of Parkinson's patients, you please do the massive online course that is set out by Dr. Stefan Lorenz's group with Dr. Weck. That is really very good. But that is more specific to Parkinson's. If you're looking broadly at neurology, come and join the International Neuropalliative Care Certificate course. That is not free. So you have to choose between the two of them.
Yeah, good evening, sir.
Yes, please.
I'm Dr. Liza. Actually, we have patients with Parkinson's disease coming and attending our clinic here. And of course, it would be nice that if you can attend that one. But then in nutshell, we can tell how can we address the people, how to take care of them in their house, in their family, so that they, with their symptoms and problems, they can face the life a little better. Just in nutshell, I wanted to just know. That's all. Thank you so much.
So again, you go through the standard routine of palliative care needs, and you will see that much of these are physical symptoms that need to be addressed. The caregiver needs support and validation. I mean, if you do these two things, then you really have addressed much of their problems. Dr. Weck, do you?
Yes, I agree. And well, I think the most important thing is to take care of the carers, as you also mentioned before, that they often experience burnout and so on. And I think well, it's important to explain how medication works, how the side effects of the medication are, to explain that illusions or hallucinations, that they have to take care of the symptoms, but it's really quite disease specific, and it's a lot of information you can give to the carers of people with Parkinson's disease. And I really think a good education for them is really useful. And well, I think yeah, there are so many problems you can address. You can address nutrition, you can address medication. So I'm sorry, there are too many things to tell you that we can make this now in this short time. I'm sorry.
Thank you so much.
Is there any patient, I mean, caregiver booklet or something that you give? So yeah, if that is there, probably we can share something that you give for the caregiver.
So there are two broad categories. One is, of course, for Parkinsonism. That's one huge burden. And for Parkinsonism, I suggest the MOOC, the MOOC will be best. It is simple enough even for any educated caregiver to follow. And when it comes to dementia, the issues really boil up towards the end of life, and there are at least two resources available for end of life care in dementia. One of them comes from Canada and the other comes from the European Union. And again, I don't think I can share it offhand, because I'll have to look on my laptop and give the linkages. But maybe if we carry this conversation further through Pallium, we could probably do that.
And I just set the link for the PDPAL project where you can find the MOOC also in the chat now. So if there are special problems or special issues you want to be addressed, then you can have a look at the MOOC. Okay.
Right.
I think that will be useful.
Thank you. Thank you.
You're welcome. And for the next question, I don't know what titubation means. Can you help me? Do you mean tremor?
So titubation is, yeah, it is essential tremor which is affecting the neck mostly. It's actually not something that you need to worry too much about treating, unless it's rarely disabling. So I would actually not, I would just reassure them and tell them.
Yes, I completely agree. Otherwise, we usually use beta blockers as metoprolol, for example, or propanolol, for example. And the next question is on treatment of atypical Parkinsonian disorders. There is no causal treatment of this disorder. So we use, for example, but it's off-label use, or not off-label, but it's not
Very
well,
useful.
yes. We use rocicotine, for example, amantadine. Stefan Lorenzo uses very often, and then the only thing you can do is treat the symptoms.
Yes.
And these are there are plenty of symptoms those patients experience. So it's also a bit difficult. If you have any special symptoms, please ask. But well, there are micturiary problems, swallowing problems, whatever. Many different problems those patients experience, frequent falls, for example. So it's if you have some further questions on special symptoms, please let me know.
So for atypical Parkinson's, what I recommend is you could visit the Cure PSP website. Cure PSP is it's a support group based out of the US. If you just type in Cure PSP, you'll get that, and you will get a fair amount of detail there. They are pretty effective. We work with them, and we hope to be setting up a linkage soon. So then quetiapine, what is the morphine dose for palliative care in neurology? I think I've given. Sorry, atypical presentations. Then delirium. Dr. Weck, do you want to handle this?
Well, I can start, and maybe you complete then. Well, first of all, you have to try to get the right environment. So you have to avoid too many disturbances. If the patient wears glasses, you have to have a look that the patient gets his glasses or his hearing aids, for example. And you have to take care of enough hydration, nutrition. You have to mobilize this patient. So these are all non-medical treatments of delirium. And then if you really need a medical treatment, we usually use haloperidol or benzodiazepines, as we it depends on what is the cause of the delirium and which illness is the patient having. So if it's a delirium from Parkinson's disease, you have to have a look if it's a hypoactive, a hyperactive delirium, and if it's a hypoactive one, you have to have a look if he needs some more levodopa, for example. So there are also, this is a very broad question. I'm so sorry.
Yeah, I agree. This is something that we could probably speak of for an hour and not be done.
Yeah.
So I would just add one thing, that in case you are in doubt, because one is that in Parkinsonian patients, you might have problems using haloperidol. So then quetiapine is probably, and that has been asked a little further, quetiapine is a fairly easy drug to use, and I suggest that most of you get used to at least using that. For morphine dose in dyspnea, just to touch on that, I mean, actually, in patients with motor neuron disease, the dose of morphine that is required is actually pretty small. For much of the course, they will get by with about 10 to 20 mg in small doses split through the day, except towards the end, when they start getting more and more breathless, and then the morphine dose climbs really steeply, and that is when the palliative care unit needs to be on guard for managing them. Admenta and Alzil are standard drugs that we use for Alzheimer's case, for dementia. Once the patient reaches the end stage, then in the prescribing, these drugs are also usually taken off. I think we finished all the questions.
All the questions in the chat. I understand most of these questions were broad. Probably we may need to have exclusive
No, but it really tells us that
on neurology.
It really tells us that these are people who are working. I mean, these are, you don't get specific questions unless people know what they are doing. So
Yes.
I'm really impressed by these questions.
And among the participants, most of them are from Chai, and most of them work in very rural areas where they don't have access to specialists, where they literally can't refer. They will be the primary treating physicians, and they have to deal from the primary to palliative part of all the illnesses. So, yeah.
Some stage, I think, Pallium, I have to speak to Dr. Raj and kind of figure out some way to work on this.
Yes, yes. As you were telling about the data from Malappuram, the data from Pallium also has the same trend.
I
When
know.
we started, we had 90% of cancer. Now it is like probably more non-cancer and mostly neurologic than any other illness. And it is very challenging for all of us to work with that.
Yeah, I think you should invite Stefan to come down to and we should actually work on that at some time.
Yeah, yeah. Thank you so much, both of you. As I said, it was a very practical points and what you have actually done. That's what we all want to hear than going through the theories or the evidence. But these are things which you both actually practice and have succeeded in doing. And that's what is really useful for all of us. Thank you so much, Dr. Weck. It was really informative about especially the telehealth, because that's something which we can adopt in our setting, even if they are working in a very rural area where they don't have access. Maybe this is a model that we can, promising model probably, if to the future neuropalliative care. And thank you, Dr. Roop, for bringing in the real case scenarios and how you managed. Thank you all the participants for